Morning, everybody. Thank you for joining us this morning. Today's session is on complex care needs in the community, and Anita Rush has kindly agreed to help us out with that one. As many would know, she's a registered nurse and has got years of experience in the industry, so she is going to take us on from here.
Good morning, everybody. Well, at least it's about 20 degrees cooler than it has been over the last few days, so that's a bonus in itself, and we've had some rain. Thank you to you, Harvey, for asking me to do this session, and I'm hoping we're going to get some debate in this session, really, more than anything. I'm going to do it a bit different than we've done it before, because when we're talking about complex needs patients, I don't know about you, but for me, when I get that email or the referral form and I read it, my heart sinks and I think, am I ever going to resolve this? Am I ever going to get this one sorted? And you go out and you do the assessment and you walk in that house and think, please let me resolve this. Please let's get this sorted. And I'm sure possibly some of you have that same feeling as I do. And I've been doing this for 20 odd years now, 25, I think, going on now. And I still have that sinking feeling when I go into complex patients' homes. So I think that we're going to start with a question from Harvey. And then I'm going to answer the question. And if any of you have got any other questions, Harvey will let me know. And then we're going to talk about equipment and complex needs as such. But I want to talk about equipment because to me, equipment is very important. Mismatch of equipment, competencies as well. And then I've got a case study, which I would like to discuss with you. So I need to do all that by 20 to 11. So I think let's get started, shall we?
Very good. Thanks, Anita. So the first question is, how would you implement a person-centered systems approach to ensure a holistic package of care?
Oh, that's a huge question, Harvey. So thank you very much for that. How would I do it? Well, for me, it's not just about one person being involved. For me, it is about the multidisciplinary approach. For me, what I would like from that person, what I'm trying to achieve, what a physio's trying to achieve, what an OT's trying to achieve, will be all different manners, all different ways of coming at it. But equally, it's about person-centered care. Now, the patient and the relatives know what they want. They've been managing this case for ages. And what we're talking about is the 4 principles of person-centered care. We're talking about care is personalised, it is coordinated, and like anybody else, whether you're an OT or a physio, we want to enable. Enabling is the most important factor. But we also need to understand the person needs to be treated with dignity, compassion, and respect. In this day and age, we are working to that principle of the person-centered care. And because it is emerging and evolving, we're still working on it at the moment. So we are giving people the dignity of what they want. I can talk to you forever about going into patients' homes and they tell me that their home has been made into a hospital and the relatives don't like the fact that they've now got a hospital as a home, that they want to have their living rooms back. They want to be able to have social interaction with the family, but can't because the person who is disabled is actually taking over the whole of the lounge. We can talk about that, but also when we're looking at complex care, we need to think about why is this person crying? And there's a lot of factors that come into this. A lot of patients and individuals that I see have postural deviation. How do you manage that postural deviation within that environment when that person is actually in the fetal position and you can't get their clothes on? You can't manage changing them, giving them good hygienic care. Those are the ways that we do it. So it's, how do we go about it? Well, it's assessment, isn't it? It's actually going out there, taking on board, listening to what the family are saying, listening to what the other professionals are saying, and then looking. And in some cases in this world now, we have to look at the cost of intervention against the cost of clinical need. And that is a big one. And it's this person-centered care is about providing that holistic package of care that meets and takes that person into account. So we all know the principles, we all know about risk assessment, we all look at the tasks, we're all looking at what the task is included. And I also look, when I'm doing this, at the tasks during the day and the task in the evening, because there are two different scenarios. The patient is tired at night. I remember many years ago, I worked as a community nurse, and I worked on Twilight. And my manager turned around and said to me that we had to go and put this 80-year-old lady into bed. And the aim of the task was to put her to bed, but equally to encourage mobility. Now, at 10 o'clock at night, this patient has been up, she's been mobilized during the day. Do I really want to walk that patient from her bedroom, from the lounge back to her bedroom at 80 years old? And that is the differential, isn't it? There is a time and a place for rehab. There is a time and a place for looking at our patients. So I didn't do it. I used to put her in her wheelchair and wheel her to the bedroom, because for me, that was the appropriate. I had risk assessed it. I'd gone through it and decided that the risk to her falling, the risk to her becoming more tired, was greater than her mobility risk at 10 o'clock at night. I got into trouble for it, but I did it. And that was, you know, that is what, that is the way forward. So it is about managing that risk. It's about the risk at the time. And for me, it is ensuring that the way that we do it meets that patient's needs. Does that answer that question, Harvey, for you?
Yeah, that's very good. Thank you for that. So we're going into these places where there's complex care, and we're trying to expand what we're doing. How do we make sure that we're working within our professional boundaries, if you like?
Right, so I'm a nurse. I would not expect to be doing physio assessments, and I would not be expected to do, well, I'm an honorary OT in some respects as well, so there are aspects of that role, but I have to work within my scope of practice. But I also have to work within my professional body code of practice. I have to work within my JD. My job description is really important. Stepping outside of that job description can actually make it a problem for my employers if there is an incident or something that goes wrong. So that is how I do it. And competency is very important. If I don't know a piece of equipment, if I don't know about any physio, then I would be referring. That's why your multidisciplinary teams are so important when you're actually working with complex patient needs. Does that answer that one?
Yeah, that's good. Thank you for that. So what you're saying is that when you've got those situations, we need to make sure that we're pulling from all these different professional bodies. Okay, so next question. What techniques and equipment can be used to achieve the task, to ensure best practice to reduce the risk to the handler and the individual.
Okay, right, I think we're getting on to the nitty-gritty now, aren't we, in the fact of what do we do. So I go into a patient who I've been called in because they've got complex needs. I sit and I ask a lot of questions. I ask how, first, and I'll also look at the mobility scale. I will look at where the patient stands on that mobility scale, whether what part of independence, do they have any independence, or are they fully dependent on the carers, that there is no way that they can help with any of the task. And then I will talk to them. I will look at what the task is. So the task might be to reposition in bed. So I would look at the bed area, I would look at the room, and then I would start to break the task down. So I would look at the task. What is the task? So the task is to care. I would look at their body dynamics. I would look to see if they've got repositioning equipment in the bed. I would look at their postural stance, whether they've got what postural deviation have they got, if that's in the fetal position, how are we going? That is a task in itself. So I would look at the task. So I'd list the task. So for a start, I would think, right, the whole task is to wash, dress, and either get this person up in a chair if they can, or I'm going to leave them in bed as comfortable as I can. So how do I break that task down? So I'm breaking it down into the washing in the bed. I'm breaking it down into getting the equipment to the bed and setting the equipment up. I'm looking at the body dynamics of that person. How much do they weigh? Are they slight? Are they heavy? And that is all part of the risk assessment. So you're looking at the individual, the patient. The individual is the carer, sorry, and the load is the patient, or the individual, as we call it. So what agency is going in? Well, who's going to do the task? Is it the family that's going to do the task? Is it the care agency going to do the task? What is the competency of the people who are going in to do that task? We all do this every day. It's no different with a complex patient. For me, then it's the environment. Where are we going to undertake this task? Is the bed going to be against the wall? If there's no other place for the bed to go, how are we going to manage that bed against the wall? Are we then going to be looking at circulation around that environment if we're going to have to put equipment in? And we need to look at other factors here. We're going to have to look at techniques, and we're going to have to look at training. And we're going to have to look at communication, whether there's any communication problems, and whether there are any language problems, barriers, and if we need interpreters to come in. So this should all be done as part of a multidisciplinary. We nowadays, I've done quite a few virtual assessments with multidisciplinary teams, and it has worked very well in the patient's home. I did one yesterday. And it's we can actually, although it doesn't take away the manual handling training, it does give you an idea. So once I've done that, and I'm looking at the what I've got in front of me, we're going to look at the patient's daily routine. We're going to look at the number of carers, what the goals are. What is the goal? What are we trying to achieve in this individual's home? Are we trying to achieve getting up, socialization? What is that goal that I am trying to achieve? And what then I will evaluate the risks, how we're going to move forward in discussion with the patient. Sometimes there is a lot of people, relatives, who are actually not always on board with what you're trying to do. So you might mention a piece of equipment, you might mention how you're going to do it, and straight away you're going to get the barriers. I don't want this. It's going to take over my home. And again, we're going to have to talk through that. It's not that easy really, because, you know, people don't always want you in their home. They don't want 6 carers going in a day, because that's what it might be. So on one side of the coin, you've got the number of carers that might be required, but you've also got the cost of that care package. And in today's environment, in today's world, the cost of having 6 people go in, or you know, 2 in the morning, 2 at lunchtime, 2 in the evening, obviously we're under a lot of pressure to try and reduce those needs. And that brings me now onto equipment, because for me, equipment, too much equipment, actually makes it more complicated. So for an example, at this stage now, I'm going to talk about my case study, because before I go on to that, I want you to understand where I'm coming from with equipment. So it's an 18-year-old disabled person, all right, who has global neurological disorders and myocephaly. Now, this has been going on for quite substantial time, and we've been trying to resolve it. And the reason we're trying to resolve it is because the parents are having to get up during the night every 2 hours to reposition the patient. So I've gone in, and we need to look at this. This patient has quite significant postural deviation. So this patient now has a sleep system in place. Patient is ventilated. So we have the added complexity of ventilated patient. So where do I start? So the parents want, and is a parent want, not a need, it's a parent want, that this person is actually repositioned right over on their side at night. So where do we start? So we've got the dynamic mattress in for tissue viability. We've got the sleep system. We had sliding sheets were also the first thing we tried, but sliding sheets still meant the parents had to get up. So that was not suitable. So then we had repositioning sheets, and we had repositioning sheets that worked in conjunction with a hoist. So you could attach the top sheet to a hoist. However, that didn't work because the motor of the hoist woke the patient up when they were doing the care, when they were doing the repositioning. And it's not only that, before you even start that, you've got to reposition the sleep system to enable that person then to be completely repositioned over on the side. You've also got to look at the ventilator tubing. Where is that going? So repositioning sheets, hoist, no good. So we then tried a sliding sheet, turning bed. That didn't work because the turning bed, again, could turn the patient up to around 30, 40, but then you've still got the sleep system, and you've still got to reposition it, and the turning bed can't do that for you, nor can a turning platform. So I then thought, well, what else is this? What are we trying to achieve here? And the remit was that the commissioning were asking that the care package at night, 2 carers at night, be taken out, and equipment does the task. I have to say that equipment doesn't always achieve the task, and we need and we do rely on equipment so much, and sometimes we have to think about the core handling skills that are involved and that individual. So we couldn't use the ventilet. The ventilet would have meant that we still would have had to get the parents up every 2 hours because it's not automated. Although it's mechanical, it needs someone to press the button. And also, because this person was on a short bed, we couldn't get the ventilet on the short bed because it was for a hospital bed, so it's for a longer bed. So following all these decisions, following all of the work that we did with all of this equipment, I looked at evidence-based practice. And I looked at all the evidence that was out there. I looked at all the evidence and I wrote a really in-depth case and said, I'm sorry, but in this case, equipment is not going to be able to do what you need for that person to achieve for that individual at night. So the need for 2 carers, one to make sure that the tubing and to assist with the care, because this patient wasn't slight, they were fully dependent and fully reliant and couldn't help at all. So we have now continued with 2 carers at night, alternate nights, to help the family. And the report I wrote, we looked at the evidence, the equipment, all the equipment we went through, why it didn't work. And in the end, it was accepted that that patient would continue with night care. And that was the resolution to that package. Some of you might have different ideas and some of you might be able to come up with some other options. But at the end of the day, we looked at all the options in that case. So that is case study number 1. So too much equipment does cause a problem. We were dealing with sleep systems, we were dealing with dynamic mattress, we were dealing with repositioning sheets, and it was a lot of equipment that needed to work together. And sometimes too much equipment actually makes the task more difficult. And actually it can be a hazard to the caregivers because they are having to remember so much on all the different equipment that they're having to use and how it would all work together as a whole. So in complex handling, I always test the equipment before I think about it. A mobile hoist with a profiling bed and a sleep system. Can I get that person, the 2, to work in tandem with each other? And I look at the environment, and the environment is absolutely crucial as well. Is there circulation within the environment? Can I get a hoist to work by the side of the bed to transfer a patient from the bed to the chair? Can I look at the heat? I mean, in this weather, it must have been excruciating for people who are individuals and for the carers delivering the care, and the PPEs that they have to wear. It's all part of that assessment. So when we're looking at the environment, we're looking at lighting. And I do a risk assessment for nighttime as well. I learned a very hard lesson when I was a district nurse and I was on night duty. I learned a lesson that there is a differential between night and day. The care plan and the handling plan had been written, but nobody had written in the handling plan or in the plan that in the access to the house was absolutely covered in nettles. So at night, you couldn't see the nettles. And at night, I went in and I got stung to pieces because I didn't know the nettles were there. So writing a really, really in-depth handling plan for both night and day is part of what I do, because it's different. It's completely different. It's different for the carers. It's different for the patient. You've got relatives upstairs sleeping, and you need to take that into consideration. So going back to the environment, carpets on the floor. Are the carpets deep? Are they shallow? Are we going to ask the family? Because again, circulation, moving a hoist over carpet, we all know that, not just with complex patients, but we know that with all patients handling, that moving a hoist is really, really problematic. We need to think about when we're using the equipment, are we putting in sliding sheets and repositioning sheets to reduce friction? And also, if the patient has got some capacity to help you, let them help you. Forget the pajama syndrome, just let the patient give you, even if they press the button on the hoist. And ultimately, is the equipment meeting the need? That is crucial. And then for me, can the task be mechanicalized? Not always, not always. It can if the equipment all works in conjunction. And then if it doesn't, what do I need to do? If I need to go for carers going at night, I will do a cost analysis based on evidence-based practice, as I said. And if I can reduce the carers to a minimum, which makes the family's well-being better as well, I will. I also will do a look at the framework for safer patient handling. And if none of you know about this framework, it was done by Orchard and Brooke in HOP 6 2011. And we talk about the risk assessment, we talk about TILE. I do TILE because I also do, in some cases, TILEAP. So I use the task, the individual, the load, the environment, the equipment, and the psychosocial aspect of that, because there is a lot of stress within that impaired hands. So I will look at a lot of the psychosocial needs of that individual and the family. I will include the family in that. I will discuss with them, and that will be part of my risk assessment. I will look at the legislation, and we've got reams of registration. And sitting on my desk here, I've got HOP 6, I've got moving and handling, clinical skills, I've got moving and handling in the community by National Back Exchange, and I've got moving and handling, a gold standard for patients in health and social care, done by the London National Back Exchange. So all of these are my reference guides, especially also with a lot of online guidance, which I use. Google is my Bible as well. So that is for equipment. I want to make sure the equipment works together. I want to know that the carers are skilled in the equipment. I want to know who's training the carers. And sometimes I can be very dogmatic, I think is the word, probably a bit more than that, in that I ask the care agency who has done the carers training, and because the skills, the actual core handling skills of those carers is essential for this to work. So that's all part of the research I do. We talk about equipment at the day, but I do go away and look at what is out there. So I look at heat and cold, and I do differentiate between night and day. I have one more case study for you, which probably might give you up to some discussion. And this is a gentleman that I've known since 1997. I knew him he's MS, and he lives with his wife. And this case is now 2020, and I still get wrapped up in this case. I still can't, there's still things I can't resolve. Now, the wife is very knowledgeable. She knows what she wants, what is meeting the needs of her husband. And I have done a lot of controversial things in this home. For a start, I've put in fixed tracking at the in the lounge. I still allow them to use the stair lift. I allow them to hoist onto the stair lift with the fixed tracking. They go up the stairs, and they are hoisted from the stair lift at the top of the stairs. The fixed tracking is then moves the patient into the bedroom. and it is such that it moves into the bedroom, but it can also move the patient into the bathroom. Patient is very dependent. He's quite big, he's not plus size, so I'm not even going to go into that today. We have put in a turning bed for him, which has worked. Their mattress at the moment is not fit for purpose, and she has chosen the mattress that she wants. I have told her that I don't agree with the mattress and that it is her decision. I've done some research on the mattress. I've asked for the pressure mapping of the mattress, but it's a mattress that I'd never heard of, but we've ordered it to see, because all of the mattresses that we've tried to supply didn't meet the needs of the both of them, because they actually have 2 beds, but they have a double mattress. My problem is the sling. This patient is highly dependent, and for her to position him correctly on the stair lift, he needs a toileting sling. It goes against convention because he needs a full body sling. So where do you start? Well, I've had so many sling suppliers in there, it's unbelievable. And I am still to this day trying to meet the needs of her. She had a sling, we had a sling which was supplied many years ago, but it's no longer fit for purpose. It's failed its Lola testing. And so we are on the look out for another one. So that's where I am at the moment with this case. Keep going backwards and forwards. Now, I know some of the OTs that have been in after I've done this and are quite horrified at the way that she hoists him. But she has been his main carer, and she has been his carer during lockdown for by herself. She does all the tasks by herself. Some of you might say to me, well, why haven't they got him downstairs and built an extension? You're absolutely right, but that she won't allow us. No way can we put in a wet room. He goes to respite. He hasn't been during lockdown, and we've got a new care agency starting with them this week. And I am absolutely desperate to get a sling sorted before this care agency come on in on call and do the care, but at the moment they're still in lockdown. So that's another complex one for you. I could give you loads, but those I think were 2 that I wanted to share with you, because 2 of them are still ongoing even after all these years of me being involved. And you think, because the patient's dynamics change as well, you know, over the years they get bigger, the equipment needs to change, their postural deviation should improve, but it might not improve. And then you've got to look at the postural management chairs as well. Right, Harvey, 20 to 11. Any other questions?
That's very, very good. That's a lot of content there. Did you have anything else to add, Anita?
No, only the fact that, you know, we all work together, we're working as a team, and I think that COVID has actually proven that, you know, how, for me, COVID has, with the families in lockdown, where the parents and the partners have had to manage by themselves, and that's because they've chosen to, how difficult it has been for them during this time, and how when we get the equipment right, the equipment has been such an asset for them. You know, we have put in quite a few vendolets for people, and the feedback has been from the family is that they wouldn't have known how to manage had they not had that equipment to help reposition their partners in bed.
Let's see. For an unconventional approach to hoisting slings,
Yeah.
would you complete additional risk assessments to highlight the family or client use this at risk against recommendations from an OT?
Okay. Hi, Sarah. How are you? Yes, Sarah. I would break the tasks down. I write my risk assessments. I don't use tick boxes. I do a full scale risk assessment, and it can take up to about, as you do as OT, Sarah. You know, I've got a risk assessment here for this patient, moving and handling, risk assessment and plan, and it's about 10 pages. And I would do the same, and I would break the task down. And it might be that in some cases I can break the task down to where not all the carers arrive at the same time. That could be dodgy, dependent on the traffic and things like that. But it could be that there would be one carer going in to prepare breakfast, and then we would have the other carer join to do the manual handling tasks and the personal care tasks. So I could break down the task into individual apple pieces, really, in the fact that you can do, okay, breakfast needs one carer. If you've got a profile in bed, you can get the patient up, and then sit them up for breakfast in bed. Then maybe the other carer could come in to do the rest of the tasks with you. So you can break it down into bite chunks.
So I think we'll wrap up there. We're just about to hit the 45-minute mark. So thank you very much, Anita. Thank you, everybody, for coming along. What everyone wants to look out for is we've got a virtual exhibition coming up. So a mini equipment show, if you like. So it's the title of it is Equipment for Improved Outcomes. So we've got lots of different equipment providers coming on, starting from your like the Venlet, your turning systems. We've got specialist seating, ramps, lots of equipment coming on there that will be good for you to see. So keep an eye out for that. It's on the 10th of September. An email will be coming around next week to book up for that. So do keep an eye out for that. In the meantime, thank you very much for joining us today. Thank you to Anita, and we'll see you again in the future.